the future of bariatrics. It may sound a little over the top. I hope it's not going to be. I hope that it's going to be useful for you to understand how bariatrics works currently and how bariatrics may work in the near future, so that you can navigate the system to your best benefit. My name is John Pilcher. I'm a bariatric surgeon in San Antonio. And for most of my career, we bariatric surgeons have been the majority physicians and care providers in the whole bariatric system. And this means that we were not responsible just for managing surgery, but also for managing and designing programs for lifestyle modification, for actually doing pharmacology, the medicines, and also doing long-term follow-up. And there have been a couple of problems with this approach. One thing is, I have to share with you, that surgeons are not temperamentally nor time structured well suited or best suited to be the managers of this full extensive process. The other problem is that this kind of partially developed system has only reached about 1% of Americans who are in need of medical and bariatric services for their obesity disease. So how did this system come about? And neither we, bariatric surgeons, nor anybody else designed this partial system. The thing that has happened is that until recently, there has not been a very good understanding scientifically of the obesity disease as a disease. And the other problem is that until recently, there has been a lack of impactful treatment options other than the surgery piece. And so this is why surgeons have been first into this field, but as we'll describe, I hope that we're going to be far from the last into the field. Many of us in the field have long envisioned a better way, already manifested in better developed systems of care, like the systems of care for cardiovascular disease or for cancer. Happily, the science of bariatrics and obesity is gradually catching up to the vision, so that it starts to make sense to talk about a full spectrum or a continuum of bariatric care. So if you want to learn what optimal bariatric care may look like soon, with fully capable diagnosis and staging and lifestyle intervention and medication treatment and potentially surgery and long-term follow-up, stick with me. I think we can conceptualize a 5-stage continuum of evaluation and treatment for almost any medical condition. And I think it's useful to have this type of framework so that we can diagnose and treat as effectively as possible. Overall, with any disease condition, we want to get the maximum positive outcome for the least practical risk and cost. The 5-stage continuum starts with the diagnosis and staging so that the appropriate treatment or treatments can be chosen, and then it guides the proper integration and evolution of therapy. I'm going to outline the 5-stage continuum as it relates to the obesity disease and bariatrics, admitting that at this time it does have some definite gaps in it, and then I'm going to go into a comparison of the fully developed 5-stage continuum in cardiovascular disease and touch on the cancer disease before I come back to what I see as the future of bariatrics. We'll start our discussion of the obesity 5-stage continuum as we would with any disease, and start with diagnosis and staging. So currently the diagnosis of obesity disease boils down to physical measurements of height and weight, and we give a little bit of consideration to the associated metabolic conditions like diabetes or high blood pressure. Staging would mean some assessment about how far along is this condition, how bad is it, how intense is it. And bariatrics is not very good at that staging right now. It recognizes the weight and not the overall medical condition and how severe or how intense it is. I think there is much, much more to be done with diagnosis and staging. We'll come back to that in a little bit. The second level of a 5-step continuum is lifestyle intervention and setting the environment. So in bariatrics, what this means is optimizing the food intake, optimizing the physical activity, and it also means getting the mind right and having an optimal work/home environment. These days in bariatrics, we just have a few simple solutions, and we tend to look for universal solutions. In other words, one food plan theoretically fits all patients, and I think that's probably not going to turn out to be the case, as we'll come back to. Level 3 of the 5-stage continuum for any disease is pharmacology, which is a fancy way of saying medicines. Weight loss medicines include good old standbys like phentermine and topiramate, and also newer medicines like Wegovy and Mounjaro. This is actually one of the most exciting areas of development in bariatrics, or the exciting areas of change, so I'm going to have a lot to say when we come back to this section. Level 4 of the 5-stage continuum is what we call minimal anatomic intervention. And this category in bariatrics would include treatment with scopes like placing balloons or electrical interventions like vagus nerve stimulation. Unfortunately, at this time in bariatrics, the minimal anatomic interventions aren't very successful, and we'll have some ideas about how that might progress in the future. Level 5 in the 5-stage continuum is major anatomic interventions. And so gastric sleeve, gastric bypass, duodenal switch, even though they're accomplished with little incisions on the outside, and we call them minimally invasive, they still are causing major changes of the internal anatomy and major changes in the way those work. And I expect that these major anatomic interventions are going to continue to be useful over the next generation of bariatrics. But I think that the improvement is going to come in better application and better utilization of these surgical techniques, better patient selection, and I'm going to come back to that in a little bit. Now, I started with the 5-stage continuum as it relates to obesity disease and bariatrics, even though it's kind of broken and incomplete, because this is really about bariatrics. But now I want to move over into cardiovascular disease and describe that 5-stage continuum so that you can see what a really well-developed continuum looks like, and so that we can then circle back and apply that to hopefully the near future of bariatrics. I'm using this term cardiovascular disease to mean the whole set of diseases that affect the heart and the blood vessels. And common examples of these diseases would be high blood pressure, heart valve disease, blood vessel aneurysm, and atherosclerotic disease that leads to blood vessel clogging and problems such as heart attack or stroke. And again, I'm walking through this better developed 5-stage continuum so that I can circle back to discuss deficiencies in the obesity disease algorithm or continuum, and make it make sense what are our hopes for the future. As you would expect, the 5-stage continuum for cardiovascular disease starts with diagnosis and staging. But there's more going on here than you might expect, okay? So first of all, in diagnosis and staging, of course, we gather information about the patient's symptoms, their physical appearance, other physical findings like pulses, lab work, etc. And many additional diagnostic tests might be used, and they're kind of implemented or put to work according to the initial diagnosis or the working theory, and what else do we need to chase down. So examples of additional tests under diagnosis and staging would be EKG, echocardiogram, a stress test, a cardiac catheterization, which is the little tube in the arteries, or specialized blood work. So providers in the cardiology field are actively aware that the presence of each cardiovascular condition affects the likelihood and the stage of several other related conditions that are all under this cardiovascular umbrella. So staging or assessing the intensity of disease is not just an intellectual process, but the staging has a direct impact on the interventions that you choose at that time. For example, a patient who shows up in the ER with a heart attack right now is going to, of course, receive lifestyle intervention, stop smoking, and pharmacologic therapy like aspirin and maybe some other blood thinners, maybe blood pressure meds or blood pressure support or reducing. But they'll also undergo an intervention to treat the heart attack by restoring blood flow as soon as possible. So staging can lead to a multi-level intervention. This sometimes means that the patient is going to jump to a major anatomic intervention such as heart bypass surgery on the same day that they first enter the cardiovascular management system. At more advanced or serious stages of a disease, a patient might have all 5 levels of intervention going on simultaneously. Level 2 in the continuum is going to be lifestyle and environmental changes or lifestyle intervention. And the cardiology team is always going to have some lifestyle changes to recommend. For example, they might recommend stop smoking. They probably are going to recommend increased activity. They might recommend physical therapy or rehabilitation to help make that happen. They're probably going to recommend a certain food plan. And lifestyle recommendations continue as a part of the plan if or when other more intense interventions are accomplished. And the lifestyle interventions might be changed or modified according to the patient's condition as it updates over time. Here's the thing, lifestyle and environmental interventions are intended to be sustained throughout the course of the disease and treatment, and to be sustainable for life. In other words, that the patient can continue to actually do these things so that these lifestyle interventions have optimal impact. Level 3 of the 5-stage continuum is going to be pharmacologic intervention, which is also called medications. And in the cardiovascular realm, there are a lot of medications that can help with cardiovascular disease. An interesting point is that the cardiovascular medicines are implemented or started as soon as they can be recognized to be beneficial, not necessarily waiting on some certain diagnostic procedure or some certain perfect lifestyle compliance thing. For example, medications would be used to treat blood pressure, cholesterol, cardiac rhythm problems, or clotting problems. Many pharmacologic interventions are implemented not to avoid anatomic interventions, but to help those interventions work better. Pharmacologic treatment is planned on a long-term basis. In other words, you don't have 3-month medical treatment of blood pressure or a 3-month medical treatment of cholesterol, as we see that in obesity and bariatrics. The medications are modified as needed, and the understanding is that the cardiovascular disease can be mitigated or controlled, but it's not eliminated. Also, multiple different medicines might be used synergistically to achieve positive effects. Level 4 in this well-developed continuum, which is cardiovascular disease, is minimal anatomic interventions. And cardiologists accomplish an amazing variety of anatomic interventions working through the blood vessels. These interventions might include dilation of a narrowing, placement of a stent, or correction of a heart rhythm abnormality. Again, it's understood that the underlying disease condition is not eliminated, but just controlled, so there's no surprise if the patient needs a repeat intervention, level 4, or a more intense intervention, level 5, or continued pharmacologic intervention, level 3. These are all understood to be continuing and to work together. Level 5, of course, is major anatomic intervention, and in the cardiovascular realm, usually the classic example is open heart surgery. We also might think about aneurysm repair, blood vessel bypass, and many patients in the continuum of cardiovascular disease management will never need this sort of apex intervention. And in fact, a positive trend in cardiovascular disease has been earlier engagement with the various disease processes, more effective treatment by stage 2, 3, and 4 level interventions, so that there's a reduced need for the major open heart surgery or the sort of apex level 5 interventions. And yet, open heart surgery is not held back if it's reasonable to predict that the less intense interventions will not be sufficient to improve the patient's health or optimize the patient's health at their particular stage of the disease. Open heart surgery is appropriately offered to patients in need, even if the patients aren't perfectly compliant with more basic interventions such as smoking cessation or exercise. This is a difference in comparison to bariatrics and obesity. I hope you're getting that point. Just to bring this point home, it's important to understand that open heart surgery is not the end of the process. The cardiovascular disease isn't cured, it's only mitigated, and the patient will need re-diagnosis as well as continuation of less intense disease management, restaging, re-diagnosis, so that they have the best health outcome. And the need for later intervention doesn't mean that the open heart surgery failed. It's just a part of the continuum of that cardiovascular disease for that patient. And again, this is a difference from bariatrics. If a person has a sleeve and they gain some weight back, what is said is that the sleeve failed or the patient failed. And I think we need to change that understanding. I'm going to come back to that in a couple of minutes. Similar to that partially developed schematic that we showed for the obesity disease process, this is a schematic of the better developed 5-step continuum for cardiovascular disease. And so you can see that moving from the left to the right, the disease management or the intervention becomes more intense. It goes from just diagnosis and staging into lifestyle, pharmacology, minimal anatomic intervention into major anatomic intervention. Not that patients have to go all the way to the right every single time, but all of those are available as appropriate for that patient's disease. And then on the bottom of this schematic, it's also important to notice that all of these levels circle back onto each other, so that think of the earlier stages as being foundational rather than stages that people pass through and leave behind. So each stage builds on the other, potentially getting to sort of the apex intervention at level 5. A little while ago, I briefly mentioned cancer as a different field of care where there's a well-developed 5-step continuum of care. And I'm not going to walk step by step through that whole 5-step continuum, but I think that there are a couple of useful points that come out of well-understood cancer treatment that are going to point back towards our main topic of bariatrics. So the first thing, I think everyone understands that there is not one cancer diagnosis. There are a lot of different types of cancer, such as lung cancer, brain cancer, thyroid cancer, colon cancer, etc. And I think everyone understands that it's really important to understand the exact type of cancer, even down to the genetics of a particular tumor, because the specifics of that particular cancer have a really big impact on what is the optimal treatment. Moving on with reference to cancer, we can say that even though some types of cancer have a significant relationship to lifestyle, cancer patients are going to receive the treatment that's most likely to result in a positive outcome while simultaneously receiving instruction for lifestyle modification. And the classic example would be a smoker with a newly diagnosed lung cancer is going to receive resection surgery, if it's likely to be beneficial, without a waiting period to prove that they're going to successfully stop smoking. One final point on the cardiovascular and the cancer treatment continuums before we get back to the obesity disease continuum. In these well-established or well-developed five-step continuum processes, each segment of the care continuum is well-staffed. So in cardiovascular disease, that means there are many cardiologists who specialize in diagnosis and pharmacologic management of cardiovascular disease, others who specialize in minimal anatomic interventions, and even others who specialize in cardiac rhythm treatment. They call themselves the electricians. There are a smaller number of cardiothoracic surgeons because that's the least common, what we might say, apical intervention, the peak of the pyramid. And the cardiologists work synergistically among each other and with the cardiothoracic surgeons so that when a given episode of a major anatomic intervention is completed and the patient is recovered, it's kind of planned and expected that the patient's going to circle back to the stage 2, 3, 4, and even the stage 1 levels of care, and there's going to be with different people to accomplish those continuing levels of care and management. And of course, my point is that the same good level of staffing applies to the cancer care continuum. There are many medical oncologists, and they manage the diagnosis, the staging, the lifestyle interventions, and the pharmacologic intervention for various cancers. There are a smaller number of cancer surgeons, they're called surgical oncologists, and a smaller number of physicians who provide radiation treatment, those are called radiation therapists. And all of these different specialties appropriately pass the patient baton back and forth and back to the oncologists after their part of treatment is completed so that the care of that disease or monitoring for that disease can be appropriately followed. With all that background in place, I'm almost ready to circle back to the five-stage continuum of care as it relates to the obesity disease. Before I actually go into step 1 through 5 and what I see as the near future, I want to talk about why we don't have this already. I mean, if we understand that a five-stage continuum is the right way to do things, why aren't we doing it? Who dropped the ball? I see at least 3 problems, 3 pervasive, long-lasting problems that so far have prevented the development of a full-stage continuum in bariatrics. Okay, number 1, I think there's kind of a persisting and maybe even a majority belief in this obesity as a choice theory. And this was the first idea and until recently the dominant way of understanding obesity. I mean, it seems obvious, doesn't it? I mean, if people eat less and or if they exercise more, then they lose weight, and they do. And so the idea is that they should just keep doing that more and harder and forever, right? Right? No. So people with the weight problem must be on some level choosing the excess weight is the way this thinking goes. It's kind of gross if you follow it to its logical conclusion. But no, as I've outlined more thoroughly in other videos, the situation is that the body has a powerful fat management system that's actually built to maintain fat levels. And in many people, this energy hormonal system is out of balance, so the body thinks it needs the excess fat storage as a survival resource. The misleading fact is that a person actually can temporarily use their will and focus to override the control system, but there's a very strong tendency for the body to pull weight back to its original set point, no matter how unhealthy we know that is from an intellectual perspective. So the problem with the old school choice focus is that it puts all the responsibility for fixing the problem in the lap of the patient. And this leads to a couple of bad outcomes that get in the way of a five-step continuum. So first of all, potentially useful treatment is held back because it's thought to be cheating somehow. Useless treatment is often recommended, including an endless succession of diet plans. Okay, try this one, try this one, try this one. Treatment is often perceived as a time-limited intervention. So people talk about a 3-month diet or 3-month medicines or surgery supposed to completely end the whole process, rather than really what we understand is it's a lifetime disease. Weight regain is viewed as a failure, and it's unfortunate. We don't want weight regain, but we need to view it more in cancer language as a partial response to treatment. And what other treatment do we need to apply? This obesity as a choice mindset also leads to resistance about developing knowledge that obesity is a disease. Okay. That first one was a cultural barrier. The second is an actual knowledge barrier. There are actual gaps in the scientific understanding of the obesity disease or diseases. And the science is very hard because the systems that are out of balance are amazingly nuanced and redundant, multi-level, and they're difficult for us to get to with our testing. Just think about a lot of this is happening in the nerve system that connects the internal organs. How do you access that nerve system? A lot of the imbalance is happening as this nerve system communicates with this nerve system, spinal cord, the reptile brain, the back of the brain. We don't have good ways of checking this out. There are probably some bloodstream hormone things that happen, but they're all happening within the blood system of the intestinal tract, which is actually separate from the blood that circulates in your arm. So you can't necessarily do a blood draw on the arm and learn about what's happening between the pancreas and the liver and the small intestine. So this is a neurohormonal system that choreographs activity among multiple organs in the abdomen, the brain, and throughout the rest of the body. And I'm not taking anything away from my colleagues, but cardiovascular disease and cancer treatment are simple by comparison. The third barrier that I think of that keeps us away from this ideal 5-step continuum in bariatrics is more of a business level barrier. It's just that we don't have enough people to fill the professions that we need. The most significant absence so far has been a shortage of a group or cadre of physicians to do all the non-surgical parts of obesity treatment. These providers, they're called bariatricians, will fill the place in the bariatric continuum that cardiologists fill in the cardiovascular continuum. And bariatricians have existed, but they've been rare so far because they unfortunately, up until this time, have not had a lot of effective tools to use. And no one wants to be an ineffective provider, so sensible people, to a large degree, just haven't gone there in the past. And I'm happy to say that's changing. I hope all that's going to provide some useful reference points as I actually go back and describe the 5-step continuum and what I hope we'll see in the next 5 to 10 to maybe 15 years. I'm going to walk through the 5 stages, and as I said earlier, I'm going to compare my understanding of the current state of play with my hopes for the near future. And my hopes are founded on the idea that better science and changes in societal attitudes, kind of moving away from this obesity as a choice paradigm, will allow better medical and surgical options that are actually offered to people based on the effectiveness of those options and not opinions about whether people deserve it. We want to extinguish obesity as a choice as a thought process. So stage 1 in the new or the near future paradigm, once again, it's diagnosis and staging. And I expect that soon we're going to go beyond the understanding of obesity as a disease and gain an understanding that obesity is many different diseases or different hormone imbalances that lead to excess fat accumulation and other metabolic damage. So many underlying problems that lead to just this gain of weight on the scale, but different versions of the metabolic disease. We'll go beyond just using weight or fat percentage to measure the disease, and we'll be better able to measure the underlying source of imbalance, such as insulin resistance. The better understanding of the obesity as a collection of diseases will lead to more accurate treatment recommendations. For example, obesity type F1 might be treated with medicine alone, whereas obesity type U4, these don't exist right now, let's be clear, might have better results with some type of brain intervention. Most types will best be treated with combination therapy. Remember my cancer comparison. We don't want to be locked into just one treatment for each patient. Better staging or a better understanding about how advanced the disease is or how serious it is will lead to better recognition of the right level of intensity of treatment. And we're going to have to understand not only where that patient is today, but what is the near future trajectory of the disease in that person so that you can select the right interventions. As in cardiovascular disease, a person who unfortunately enters the system at an advanced or more intense stage of the disease will be offered a full court press and potentially including all 5 levels of intervention more or less simultaneously. Hopefully we'll be intervening more on the stage 1, stage 2 level so that we only gradually work into the later stages and less so. I think that advances in the diagnosis and staging will at least involve the ability to have real-time monitoring of some of the physiologic parameters that we're trying to modify. We've scratched the surface of this with continuous glucose monitoring. You've all seen the Dexcom commercials on TV or the Libre commercials on TV. I hope that we'll be able to do this with many different parameters, not just glucose monitoring. I feel that the role of the gut microbiome needs to be figured out, and it may have something to do with the obesity disease and probably many, many more things that we're not considering right now. Level 2 will continue to be lifestyle and environmental interventions, but these are due for an upgrade. We're beginning to understand that food's not just calories, but also that food is hormonally active inside the body. I think we'll find that different foods affect different people in different ways, and with a better understanding, we'll be able to recommend food plans and exercise plans that are both effective and sustainable. As an entire society, we're going to get better at setting the environment and modifying the environment to facilitate the desired lifestyle changes. Lifestyle and environmental management will of course understand that most people with the obesity disease don't have an eating disorder, but instead suffer from physical drives that lead to unhealthy levels of fat storage and other metabolic problems. Level 3 intervention for the obesity disease will continue to be pharmacologic intervention, in other words, prescribing medicines. And there have been weight loss medicines that have been around for decades, but the field's been stagnant until recently, and several newly effective meds have arrived on the scene. There are more in the pipeline, and there doesn't appear to be any end in sight. And I would say that this part of the bariatric continuum seems to be entering a virtuous cycle. And in this virtuous cycle, more effective meds lead to more engagement to treat the obesity disease, leads to more interest and investment in the science of obesity. This leads to improved acceptance of obesity as a disease over obesity as a choice, and all this can lead back to better medication options and earlier appropriate intervention, as well as a better developed continuum of care. And I don't know exactly what the future of pharmacology holds in my field, but the meds will be easier to take, and that might be pills or implants instead of shots. The meds will be more effective, they'll be lower cost, they'll have less side effects, and some pharmacologic treatments will be given synergistically, multiple pharmacologic treatments, just as we see in cardiovascular disease today. Someday there may be a vaccination or gene therapy for some types of the obesity disease. On a societal level, we're going to get over the idea that people with the obesity disease don't deserve medical treatment as much as people with more established medical conditions like diabetes. We're hearing these arguments in the press all the time. Moving on to level 4, I want to restate that one of the underlying assumptions or principles of the 5-stage continuum is to use the least risky, least intense intervention that's going to achieve the goal of bringing the disease under control. And so, in theory at least, minimally invasive interventions, level 4, are going to be better than or a prelude to major interventions at level 5. Unfortunately, in bariatric surgery, so far, minimal anatomic treatment has been a pretty big disappointment. I'm still optimistic that a better understanding of the diseases is going to lead to new minimally invasive alternatives. These treatments might be things like a focused alteration or stimulation of certain nerves, or interventions in the pancreas, minimal anatomic interventions, although they're not available yet. Level 5, of course, is the major anatomic intervention such as gastric sleeve, gastric bypass, duodenal switch. And I think that the first near-term improvement is going to be that we as a bariatric profession are going to be better or smarter at selecting the right surgical intervention for the right patient. In the current state of play, we have conversations with patients and ask them which surgery they like the best and which one did their sister have or their teacher. And it's not quite that basic. We have some factors, but I think we can do much better with genetics and hormonal understanding to guide us on the right surgical treatment. I expect the surgeons of the near future to continue accomplishing the major anatomic changes with less trauma, less risk, and quicker recovery. I think the next generation of surgeons might manage major anatomic change accomplished by nanobots using IV injection. I mean, it's a little bit sci-fi, but as we think 10 and 15 years down the road, who knows how that's going to work. One really important stage that's kind of outside my 5-stage continuum is actually the idea of preventing a disease from happening in the first place. And as we're talking about obesity disease, that really would be the best outcome for people and for society as a whole. As I sit here today, I don't know how we do that. It's going to be hard because even the little bit of understanding we have right now about the obesity disease indicates that it often begins, the imbalances often begin while that person is in the womb, before they're even born. Optimistically, once we understand the genetics and all the environmental factors that lead to the various different subtypes of the obesity disease, we hopefully will be able to intervene to balance against genetic influences and to modify environmental, even potentially womb factors before the obesity disease kicks in. Congratulations, and also thank you if you stuck with me all the way to this end of this kind of long and meandering philosophical video. I do hope this big picture overview helps you navigate the current and the near future bariatric continuum of care. Stay well.